Welcome to Masterclass 5, Module 4, on Comprehensive Person-Centered Carer Assessment and Support. This module relates to the final core requirement for implementing carer support that we introduced in Module 2. That is, having a protocol for assessing carers and responding to the assessment in order to ensure consistent, comprehensive assessment of carer support needs and a consistent response. This is of central importance. Practices can move forward considerably in supporting carers by being aware of carers' role, identifying them consistently, and developing a readiness to support them in the practice. However, to really support carers, we need to have a clear process for assessing their needs and providing supportive input accordingly. We will stress the importance and benefits of adopting a person-centered approach to this. As an illustrative example, we're going to use the Carer Support Needs Assessment Tool intervention, the CSNAT intervention for short. So we will cover what we mean by person-centered care in this module, the Person-Centered Carer Support Needs Assessment Tool intervention, which consists of the CSNAT, that is the tool itself, and the stages of the CSNAT approach. We'll look at lessons we've learned on the way and how to get started on implementing the CSNAT intervention for those wanting to adopt the intervention in practice. Although we use the CSNAT intervention as an example, this module provides you with key principles for assessing and supporting carers, even if you may not want to adopt the CSNAT intervention itself. So let's look at defining person-centered care. There are lots of definitions, but in essence, it is a collaborative approach between clinicians and service users, working in partnership with people rather than doing to them, and clinicians taking a step back from being the expert. It is holistic, thinking beyond the immediate disease and looking at the whole person. As we highlighted in Module 1, policy guidelines stress the importance of person-centered care for carers as well as patients, but do not specify how to achieve this for carers in practice. Now, you may have heard reference both to person-centered care and personalised care, which may be confusing. So we'll pause a bit to consider where they fit together. These are very similar and overlapping concepts. The NHS England Comprehensive Model for Personalised Care brings together the healthcare concept of person-centered care and the social care concept of personalisation. The healthcare concept of person-centered care involves personalised care and support planning, shared decision-making, support for self-management, social prescribing and enabling choice. The social care concept of personalisation involves personalised care and support planning again, and personal budgets. However, as you may gather, although these concepts come from different starting places, they represent a similar relationship between the system and the public. To clarify where the CSNAT intervention sits in this context, the person-centered approach from a CSNAT intervention perspective is rooted more in healthcare concepts, but encompasses the broad principle of working with carers rather than doing to them, which can be seen as a common aspiration both for health and social care. The intervention consists of a practice tool to help carers identify, express, and prioritise their support needs, which is then used within a defined person-centered approach to carer assessment and support. So the CSNAT intervention starts with an evidence-based, comprehensive tool, self-completed by carers to express and prioritise their support needs. However, a tool or form in itself does not help us support carers and is not in itself person-centered. What is important is how it is used. The tool therefore sits within a 5-stage person-centered process of assessment and support that is practitioner-facilitated but carer-led. So we're going to tell you more about development of the CSNAT tool itself, person-centered CSNAT approach, and the lessons that we learned from this along the way. Development of the CSNAT tool started as a response to the policy background that we touched on in Module 1. Namely, policy highlighted that carers' needs should be assessed and addressed, but there was little guidance on how this should be achieved. There was furthermore a lack of feasible assessment tools for use in practice, and no consistent approach to carer assessment in practice. Carer assessment was mainly conducted on an informal basis. We therefore started on what became an extensive program of research to develop, pilot, test, trial and implement the CSNAT intervention. We started by developing the CSNAT tool itself, working with 75 carers and testing it with a further 225 carers. The contents of the CSNAT covers carer support needs both in their role as co-workers and as clients. You may remember this from Module 1. So to recap, as co-workers, carers need support with knowing who to contact when concerned, understanding the patient's illness, knowing what to expect in the future, talking to the patient about their illness, as well as practical matters such as managing symptoms, including medicines, equipment to help care for the patient, and providing personal care for the patient. As clients, carers need support with their own physical health concerns and dealing with their own feelings and worries and beliefs or spiritual concerns, as well as practical help in the home, financial, legal or work issues, or the respite issues of having time for themselves in the day or an overnight break from caring. It is worth noting that the majority of these support domains mainly require healthcare practitioner support, particularly those relating to the co-worker role, as these mainly relate to the patient's illness and how to manage this. However, carers' own health concerns are also likely to require healthcare input. The remainder of the support domains, where carers are mostly in the role as clients, may be closer to the remit of statutory assessments. Given these concerns, it may be important to start overall assessment of carer needs within a healthcare context, but this may also help trigger early referral to statutory carer assessment. However, we won't know for sure what type of support carers need without further probing. The CSNAT covers broad domains to help carers think about their needs. They do not tell us what supportive input would then help them, which is something we will come back to later. From feedback from carers and practitioners, what has come up time and time again is the importance of the CSNAT tool in terms of aiding the visibility of support needs. Carers note the value of seeing the CSNAT domains written down to enable a conversation, as carers so often have said they don't know what to say when someone asks, "What help do you need?" Like one carer told us, "These are the questions that are in your head, but you don't even know that they're in your head. Whereas if something's written down, you can ask people. If they don't know, you can be signposted on to somebody else to get the answers." Practitioners also noted the benefits, as one practitioner said, and quite often in that kind of situation it is, "Oh, I don't know what I want," They can't focus. But the CSNAT allows them to focus on that because it's asking them specific questions. Next, let's look at how the CSNAT tool is used and the 5 stages of this process. The assessment tool alone does not enable us to support carers. It is how it's used and the process around it that matters. So what do the components of the process need to be? It involves creating a space for the needs of carers to be considered separately to the needs of patients, and for carers to have space to consider what they need to carry out their role. Then, having a follow-up assessment conversation about needs identified and prioritised by the carer rather than the practitioner, and the supportive input carers feel would help. And then in terms of any actions, focusing on and responding to carers' self-defined priorities and supportive input. Practitioners have found this process opened up different kinds of conversations with carers than they had before, and they have been able to get a lot further. Let's look at the 5 stages of this process in detail. Firstly, introducing the CSNAT. The key messages to get across here are that this is for the carer to consider their own needs. It's the start of a conversation on how carers can best be supported, and an assessment conversation will follow. How you would introduce the CSNAT in practice will depend on how you normally come into contact with carers, whether you would see them during a contact with a patient or on their own. You may want to only introduce it at first contact and let the carer review the questions and complete in their own time. But then a follow-up contact must be arranged with you or a colleague. If you see the patient and carer at the same time, you may introduce it to the carer at the start of the contact and leave it with them to complete while you are reviewing the patient, and then follow up with the carer at the end of the contact. Alternatives may also be to introduce a CSNAT by post, email or telephone, but it is then important to explain how the process will then work. Some practice teams have put the title About You on front of their CSNAT tool. This simple introduction immediately clarifies that this is about you. Further, the message to convey is again that this is a conversation starter, not another form or questionnaire for them to complete with no follow-up, and it's not an information leaflet. If you refer to it as a questionnaire, carers will perceive it as a questionnaire, so how it is introduced to them is really important. Next, at stage 2, carers need time to consider their support needs for each support domain. For most, this will be the first time they've thought of their own needs, and the time required will depend on the individual. Carers may wish to consider their needs when the CSNAT is first introduced, for instance by looking at the CSNAT while you are with the patient, or following on from the contact when the CSNAT was first introduced. For example, they may reflect on their support needs on their own during a quiet moment, using the CSNAT as a prompt. Chat about their support needs with family members or friends, using the CSNAT as a point of reference. Or they may discuss their support needs with the person they are caring for. You may wonder, how will I know what are the most important support needs for the carer? Well, part of the process of carers self-completing the CSNAT is that they also prioritise the domains that are most important to them at the moment, not the practitioner. We therefore have the statement at the bottom of the tool asking carers to consider which of the domains they most need support with at the moment. This then forms the basis for the assessment conversation. It is important to realise that the support needs that are prioritised as most urgent are not always the ones they tick as requiring most support. In fact, very often they are not. For stage 3, the assessment conversation, the principle is to focus the conversation on the domains prioritised by the carer. practitioners viewing the CSNAT often worry that they will have to discuss all 14 CSNAT domains. You do not. The 14 domains help carers consider the full range of support needs carers may have. However, the individual carer usually only prioritizes 2 or 3 domains, and you can limit the assessment conversation to these and aim to pick up any others at a later review date. This process enables the conversation to focus on a small number of issues, but ensures that these are the ones that are most urgent and important to the carer. In practical terms, when to schedule the assessment conversation about the domains prioritized by the carer will depend on how you work with carers and patients. It could take place when the CSNAT is first introduced to the carer, completed at the contact itself, or at a follow-up contact by you or someone else linked to your team, or via a telephone call. For instance, situations where the carer is not local and or not usually present during patient contacts. Alternatively, the carer may make a phone call to you or a colleague once they've had a chance to consider their needs. They may prefer the privacy that this option allows. Carer support needs are individual. One size does not fit all. It is therefore crucial to ascertain what the individual carer needs support with in relation to each domain of support. This is why an assessment conversation about support needs and what would help from carer's perspective is so important. For example, we looked at the need for more support with personal care in a group of carers for people with motor neuron disease. What this meant for individual carers differed greatly. For some, this was about finding out how to do things, for instance, how to move or turn the patient in bed, to manage patient falls, or dealing with soiling, or training on lifting, bed baths or catheter care. But for some it may be about general understanding, for instance, of changes in mobility as motor neuron disease progresses. For others, managing the strain of being the only person providing personal care, or accessing services to help with personal care, or managing the cost of paying for personal care, or a number of other issues. The main point is that the support needs are highly individual. They are mainly simple, but each requires a different tailored input to help that carer. Following the assessment conversation, by stage 4, you should be able to ensure the action plan that follows takes into account what carers feel would help them, rather than moving straight to suggesting what help is available. The supportive input required may be facilitating self-help or family help that carers may wish to access themselves or via family members or friends. You might directly deliver some very simple support yourself. This could be active listening, providing reassurance, giving information or offering advice. You might signpost the carer towards sources of support, but leave the carer to access it. Or you could refer the carer to a service which can provide further support, with their consent. A lot of what is needed is direct advice or support at the time of the assessment conversation, or facilitating self-help, and not necessarily further intervention or referral. The supportive input that carers need is often different and simpler than what practitioners expect. A key part of the process is a shared review. Carers' needs change over time, so this is not a one-off assessment process, and review is required. Ideally, it is about a more proactive approach and agreeing a plan for review of the assessment with the carer, rather than wait for a problem to arise. For instance, you may record a date for when review will take place. So to bring it all together, person-centered care from a CSNAT intervention perspective is about working with carers rather than doing to them. Carers are active in defining problems and their solutions. Solutions are chosen by carers rather than for them. And it makes the process of assessment and support explicit to enable carers to say what matters to them regarding the support needs. Ensure support planning is tailored to individual needs and preferences, and it entails a collaborative, holistic approach based on partnership, where clinicians take a step back from being the expert. Now we'll just pick up some general lessons learned about carer assessment and support along the way. As we have explained, carers have support needs both as co-worker and client. If we are to be truly person-centered, it is important that we are not selective in terms of exploring support needs and only focus on one element, but that we are comprehensive and holistic in our assessment and consider the different facets of their caregiver experience. Lesson 2 is that one size does not fit all. Carers' needs are highly individual. If we are to be person-centered, it is important that we do not presuppose what the solution is to a carer's problem. We need to understand their problem first and ascertain what solution works for them. Knowing that a carer wants more support with symptom control and medicine management tells you very little until you delve further into their individual problem. For one carer, this may be about understanding the patient's different medicines. For another, this is about being involved in discussions about symptoms to give a more accurate account of the patient's symptoms to ensure a better basis for symptom management. For some, they may need to be shown how to give injections or managing a syringe driver appropriately. And again, for others, it may be about knowing what to look out for and accessing help with symptom management out of hours. Each of these requires a different response to address the actual need and give the most effective support to that carer, and at the same time support the patient's care. Lesson 3 is that formal assessment is needed. Existing carer assessment is often informal and practitioner-led. It's easy to ask about what we are most familiar with, what we assume will be the problems based on our experience. But such informal assessment will necessarily be selective and can be hit and miss in identifying what really matters to carers. Important needs may therefore go undetected or until a crisis occurs. As one nurse commented, "What I found particularly useful when using formal carer assessment was the things I thought the carer might not be able to cope with were the things she was coping with, and the things she wasn't able to cope with, I was quite surprised." Often what may seem simple to a practitioner and overlooked may be a big problem for carers. Formal, more comprehensive approaches are needed that can help capture what matters to that individual. Lesson number 4 is that carers are unlikely to ask. Carers often do not see their own needs as legitimate and therefore will not ask for or seek help and are unlikely to volunteer their own needs. As this carer said, the nurse used to come in and say, "You're important as well. It's not just about your husband." Whereas I said, "That's all I want you to concentrate on." They therefore need support to express their needs from their perspective. A proactive approach and again an established formal assessment process can help legitimize needs, and a formal assessment tool can convey that it's okay to ask about needs. So a formal process can help legitimize need. As put by one carer, the reassurance that you're not the only one. It's not selfish to ask for help for yourself. If you see other people doing it, then it's okay to do it yourself sort of thing. Or as stated by this practitioner. But I think what this does, it puts it in the minds of the carers that they're allowed to have needs and that it's okay to ask for help because we've made that introduction. We're just briefly going to finish the module by looking at how to get started on implementing the CSNAT intervention if you want to use it. We'll touch on learning units, preparing for training, and accessing training and license. Through our work with hospice services, specialists and generalist services, we have learned what support and resources are needed to implement the CSNAT intervention. This represents a change in practice. We have learned that there are two main components to this implementation. Firstly, the training individual practitioners need in order to work with the CSNAT intervention and adapt it to their practice. Second, what the organisation needs to put in place to implement the change to a new way of working with carers within the organisation. Correspondingly, we have developed an online training and implementation toolkit to address this, which has two parts. Learning Unit 1 is for everyone who will be involved in using the CSNAT intervention in practice. An additional Learning Unit 2 is for the team within the organisation who will lead on implementing the CSNAT intervention. This covers planning, piloting, training and sustaining this change in practice from an organisation perspective. Each learning unit takes approximately 2 hours, but we recommend factoring in blended learning group work in addition to make learning more effective. When preparing for training, it is important to get support from practice leads. Investment in terms of time and resources is important for successful implementation. This includes the provision of protected time for practitioners to complete the learning units relevant to them. We recommend forming a project facilitation team and to appoint champions who should undertake both Learning Unit 1 and 2 to support implementation. We recommend preparing for a blended learning approach. The learning units work best if combined with group discussions. It is important to ensure there will be scheduled time for this. Finally, it is important to ensure good IT facilities and support, to ensure access to online learning, group support and buddying to counter any difficulties. See our web link on the slide for further resources on this. You may access training and materials directly from the Daffodil standards, as indicated on this slide. You may also access this through CSNAT.org. Training is free. It just requires registration. Use of the CSNAT intervention is free. But practice members need to undertake training first, and then the practice can obtain a CSNAT license for use of the intervention. Again, see CSNAT.org for details. So, to summarize some of the main points of this module. The benefits of a formal, comprehensive, person-centered approach to carer assessment and support include that they help carers feel it is legitimate to consider their own needs. It helps carers visualize needs and organize their thoughts. It focuses the discussion between carer and practitioner on what is most important to the carer. It ensures carers' own solutions are considered first. And it gives a clear plan for action and documents the support given. Finally, supportive input required is normally smaller scale than practitioners think.